All right, hello and welcome everyone to the 2021 UNC Water and Health Conference, and thank you for joining today's verbal session on monitoring and evaluation. My name is Timothy Purvis from the Water Institute here at UNC, and I am the room host for today's session. So before we get started, we have a couple of announcements. First, we have a networking event hosted by our sponsor, Remo, today at 3:30 p.m. Eastern Time, which would be a great opportunity to connect and network with some other people here at the conference. You can find out more details about this on the actual conference platform, and you can register for the actual event through the conference platform as well by going to Agenda, all agenda items, and then selecting that from the list of today's options. Additionally, we have the Late Early Show, which is happening tomorrow morning at 7 a.m. Eastern, which is a great opportunity as well to have a recap of what happened in today's sessions, especially in today's plenary sessions. If you weren't able to join those, it's a great opportunity to also hear from Dr. McCullough and Dr. Salzberg about their thoughts on how the lessons learned from today's plenaries could be applied in South Asia in the future. Additionally, we have a few technical instructions just for everyone. So first of all, this session is being recorded for anyone who isn't able to join live. And with that, we do have everyone except for the presenters being muted throughout the duration of this presentation. Also, so that we can keep record of the chat, once the session is over, we will have all of our chat going through the Pathable site. And so that is the way that you actually joined this session today. There's this chat window where you can be posting all of your chat. Additionally, our speakers have uploaded their files into the files panel that you can navigate to on the same page. Additionally, we want to say a thank you to our sponsors, so German Cooperation, GIZ, and PMG. Thank you for your support and enabling today's work. And so we have three great presentations that we're going to be going through today. We're actually going to start with Laura Kmentt, and then we'll be moving to Megan Lindmark, and finally to Meyer. And so that is all from me. So I will stop sharing. Laura, the floor is yours. If you want to share your screen, you have 10 minutes.
Right, okay. Okay, so I hope everyone can see this. So hi, my name is Laura Kmentt, and I'm going to present to you my research on drivers of WASH in healthcare facility service levels as part of a 14-country evaluation. So this research was conducted by me and Ryan Cronk, Ben Tidwell, and Elliot Rogers, and our paper on this is available in the H2 Open Journal if you'd like to have a look at that. So the data for this research was actually collected by the University of North Carolina and World Vision in between 2017 and 2018. And I'm not going to go in too much into the exact methodology of how this data was collected, but it's publicly available on the UNC Dataverse. And it's data on just over 2,000 healthcare facilities in 14 different countries, which are Ethiopia, Kenya, Rwanda, Tanzania, Uganda, Malawi, Mozambique, Zambia, Zimbabwe, Ghana, Mali, Niger, India, and Honduras. And how this data was collected is the healthcare facilities were actually selected as part of a sampling frame of a larger study being conducted at the time. And enumerators then went to the selected healthcare facilities and aimed to interview the head doctor if they weren't available, the head nurse, and if they weren't available, a nurse that had been employed at the facility for more than 2 years. And they asked them questions, quite a long survey on sort of healthcare facility characteristics in terms of how many patients were at the facility, what kind of care they were offering, the water, so the source type, distance from the facility, were they treating the water before use, was it stored in a certain way, sanitation facilities, so access to own sanitation facilities, distance to the sanitation facilities, usability, hygiene in terms of hand hygiene, and also sort of facility hygiene, environmental hygiene, like the are the counters clean? Are the floors clean? Are bed sheets washed between patients? And then also waste management of infectious and sharps waste. And then also some questions on sort of administration and training. So is there a wash policy at the facility? Is there a budget? And so on. So what we then aim to do in our study is, firstly, we sort of summarized and described the wash service levels that were present in these facilities, in these 2,000 facilities, and just to sort of gauge to what extent WASH is implemented in these countries. And then we tried to identify possible drivers of service level improvement. And what this means is we selected certain managerial variables, we called them, and tested associations between those managerial variables being present and then sort of better service levels at facilities. But I'm going to talk a bit more about that in just a bit. But just to update you on sort of the results of our descriptive data analysis in terms of water, sanitation and hand hygiene. So 52.4% of facilities had at least a basic water service level, so a safe source that was accessible to them and that was on the premise and actually was functional. 64% treated water in some way before use, and the most common way in this data set was chlorine tablets, and 62.5% were classed as low risk for E. coli. So that's according to the WHO definition of less than 1 E. coli per 100 mils of water. And how this was determined was that when the enumerators went to the facilities, they asked to be served some drinking water, and they then took a sample from that and tested it. 90% of facilities had access to their own sanitation facilities, although the functionality and sort of cleanliness of them probably varied quite a lot between facilities. 20% still reported open defecation. 16.2% had at least basic hand hygiene service level, so they had a functional hand hygiene station at points of care and also within 5 meters of sanitation facilities. 22 had functional hand hygiene stations at sanitation facilities, and 57 at points of care. So now going on to sort of the second aim of our study, which was to, as I said already, to investigate the effect that certain software interventions or managerial interventions might have on improving WASH service levels. So we decided to investigate the effect of 3 managerial variables, which were a WASH focal person being present at the facility having a WASH policy, and WASH training being offered to staff, and the effect on the likelihood of facilities having improved service, sort of better service levels in certain variables that I'm still going to talk about. But just to give you a bit of background, 53% of the facilities interviewed said they did have a designated focal person, but obviously the definition of this could vary between countries. 67% had a WASH policy, and 50% said that they conducted WASH training for staff, of which 50% had held a training in the last 6 months. Obviously the sort of curriculum of the training and also the sort of frequency obviously varied quite a lot. But the most common people to attend these WASH trainings were nurses. So what we then did, we'd conducted univariable and multivariable logistic regression models and tested to see if these managerial variables were present, were facilities more likely to have at least basic water service level, treat their water before use, their water be low risk for E. coli, the facility being open defecation free, them having access to their own sanitation facilities, and at least basic hand hygiene service level. And after sort of crunching the data, we actually found that there were actually some quite promising results. So we found that a focal person being present and a WASH policy being present led to really a sort of substantial increase in likelihood of facilities having better service level in respect to those 6 variables that I just talked about before. So for instance, when a WASH focal person was present at the facility, they were more likely to have access to their own sanitation facilities. They were more likely to treat their water before use, and they were more likely to have at least basic water service level. And then even more so when a WASH policy was present at the facility, they were more likely to have access to their own sanitation facilities. They were more likely to be open defecation free and to have at least basic water and hand hygiene service level. WASH training only showed a significant increase in the odds ratio of facilities being more likely to have basic hand hygiene service level. And of all of these 3 managerial variables, there was no sort of significant change in odds ratio or likelihood in facilities having low E. coli contamination risk. So that's sort of
2 minutes.
What we found. Thank you. So getting to the end, what does this kind of mean maybe for the future of WASH interventions? And we've heard quite a lot today, for instance, in the policy panel discussion, the sort of importance of maximizing human resources and how sort of effective hardware and software approaches might be. So by kind of having these sort of committee-based, community-based, or sort of managerial interventions, that significant and long-lasting and potentially sustainable change might be able to be affected. What there still is there is a need still for research on how we can create this sort of enabling and facilitative environment in order for these interventions to happen. So not just sort of send the hardware, but sort of have the environment, have it on the high up on the country's policy agenda to sort of create those kind of those interventions that are great, mostly run then by the local stakeholders. So yes, so I think this is promising in terms of that. So thank you very much for your attention, and I'll take any questions now.
Thank you, Laura. And so once again, if anyone wants to ask a question, they can type it into the Pathable chat, which is that page that you were on to get into this call. So while questions are being asked, oh, Victoria's got one. I'll save mine. So were there any criteria? So Victoria asks, were there any criteria for what qualified as a facility having a WASH policy, or was it up to the facility to define?
Yeah, so that actually was kind of tricky when we were. So first, thank you for the question. It was a bit tricky when we were actually crunching these data. It was very facility specific. So it was a kind of yes or no, don't know, or decline to state answer. So that is something that probably did vary quite a lot between countries. There were sort of, and between facilities, there were multiple sort of managerial questions, but they didn't kind of provide a lot of detail exactly into what qualified, as you say, for instance, an IPC or WASH policy, or for instance, the same with focal person, what exactly were the sort of duties of the focal person was probably different from each facility.
Thank you for that. And also, if follow-up questions are asked, they can also be answered by our speakers in the Pathable chat. So we have a question from Saskia. So did you look at potential financial drivers like funding or budget available for WASH?
So that was not in the scope of this, again, sorry, thank you for the question. That was not in the scope of this research. We have conducted interviews also that were then not published in this paper, but sort of with local employees by World Vision, for instance, getting sort of their insight onto what kind of this facilitative environment might look like in the countries in which they were, and we don't have specific information on the financial kind of availability in each country, but that is something that these the sort of staff of World Vision did say that was, as you can probably imagine, quite difficult, quite a sort of a problem, definitely not enough funding, it can be assumed. But yes, no, we didn't look at that sort of in detail. It was really sort of investigating what can be found in this data set, and that was not included in the data set.
Thank you for that. So Ben Tidwell asks, did results seem consistent across countries and contexts?
No, that actually was thanks, Ben, for the question. There was actually quite a large variability between countries in terms of their service levels, and that does kind of lay the ground for further research looking into specific kind of policy backgrounds in countries that had such differing service level outcomes, but they were very, very different. So some countries really did have, I mean, as far as you can tell from the data set, obviously I wasn't there, I didn't see the facilities myself, but as far as you can tell from the data set, they did really have different service level outcomes. So it wasn't consistent, the results really across all the countries. And probably, but if we were to look into the actual context in the countries, we might find clues as to why that is the case.
Fantastic. And we have time for one more question. We're going to go to Joanne Barlow. So Laura, any thoughts on why criteria had no relationship with E. coli when a focal person had impact on treatment?
So thanks for the question. Yeah, I mean, it's difficult to say why that would be. I mean, I think it might go back also to what exactly the role and the sort of capability of these focal people are in the different healthcare facilities in the different contexts. I mean, they might in some countries or in some facilities have had a substantial impact if they just had that sort of certain responsibility in that facility, but sort of overall in the data set we didn't see that when we were doing our logistic models. I think maybe a lack of a standardized job description, as it were, for a focal person might be somewhat of an answer to that. And maybe if there was a sort of standardized description, maybe then we would see it in the data.
Thank you for that. Definitely something with a lot of nuance into it. So you do have one more question, but sadly we're out of time. So if you want to answer that out of session, that would be great. And so if you want to stop sharing screen, we'll transition over now to our second speaker. Oh, and I apologize if I forgot to mention Laura Kmentt joined us from the London School of Hygiene and Tropical Medicine and Queen Mary University of London. So our second speaker for the day is Megan Lindmark out of the University of Iowa. Megan, if you want to share screen and begin, you have 10 minutes.
All right, thank you so much. As Timothy mentioned, my name is Megan Lindmark, and I'm going to talk to you all today a little bit about passive chlorinators and their use in Honduras, as well as the ways that we can assess the effectiveness of these systems. So what is a passive chlorinator? Passive chlorinators are a class of drinking water treatment technologies that are usually installed within a community distribution system or within an institution, and they're usually installed in line or end of line. Use a variety of forms of chlorine to treat drinking water without the end user actually having to actively participate in the process of chlorination, which means that the end consumer of the drinking water can simply collect their drinking water as they usually would without actually having to do the chlorination themselves. So specifically, I'm going to talk to you all a little bit today about the chlorinators distributed and deployed by EOS International, which is an NGO that works across Nicaragua and Honduras. They've installed these systems in 1,300 communities there And they work pretty simply. They're constructed out of PVC, and water flows in here at this source water point, and then can either pass through a bypass or through this chlorination chamber that holds a series of chlorine tablets. Now, these systems would usually sit on top of a tank that connects to a full-scale distribution system. And you could control how much dose of chlorine is received by splitting water either through the bypass or through the chlorine tablets. So as I mentioned, these systems have been installed in over 1,300 communities, but a number of important research questions remain. And the purpose of my talk today is to answer a few of these research questions. So the first I hope to answer is, do these systems actually provide safe drinking water? And second, how effectively do they do so through time? Is their usage sustainable? And finally, in the cases in which they aren't delivering safe drinking water, what are the leading drivers of this system failure or lapses in chlorination? So before I get to the data, I want to provide just a little bit more context about what EOS International does in Nicaragua and Honduras. EOS International uses a circuit rider model where their circuit riders or technicians visit these communities regularly, and they help a community water board in each community install these systems. And the community water board, which is made up of members of that community, they are locally elected, and those community members then are responsible for purchasing the chlorine tablets and actually refilling them into the chlorinator itself. These technicians or the circuit riders then visit these communities on a monthly basis to perform chlorine monitoring. So they take a sample of water from somewhere in the distribution system and determine how much chlorine is present. And then they also determine, if there's no chlorine present, what the cause of any kind of system failure might be. So since 2013, over 12,000 chlorine data points have been collected across 300 communities. And specifically today, I'm talking to you about the communities in Honduras. And so as I mentioned, they can be collected at a variety of points within the distribution system. This could include the tank directly below the chlorinator, or any house within the distribution network. So the first house would be the closest in proximity to the tank on that line, and the last house would be the estimated furthest point within that system. Some of these communities also have health centers or schools, which can serve as additional sampling locations. So how then does water quality change across this distribution system? So I'm showing you now all of those same sampling points I just showed you. I'm showing you the free chlorine residual concentration, and I'm showing you a box whisker plot. And I just want to really quickly run through what I'm specifically plotting in this diagram. And that is, the box itself shows the 75th percentile at the top, the 25th percentile at the bottom, and the median is that middle line. And if there's a dot above or below the box, that's the maximum or minimum. And if there's no dot, then the 75th percentile or the 25th percentile is the respective maximum or minimum. So what's particularly valuable about this figure and this data is that it shows that all of the point of collection samples, so points at which people could actually be collecting water for consumption in the distribution network, are above 0.2 milligrams per liter free chlorine, which is the WHO standard for safe drinking water and adequate disinfection. So the median values again fall above that, and they also fall below this 1.25 milligrams per liter, which is one reported taste aversion threshold, which is the concentration at which someone might be adverse to drinking chlorinated water due to the taste of chlorine. So 67% of samples delivered to a point of collection by these chlorinators fall within this range of 0.2 and 1.25 milligrams per liter of chlorine. So this is considering the point at which someone collects it, but how does source water play a role in determining ultimate disinfection level? EOS chlorinators use two different types of water. So some may use groundwater and some may use surface water from a variety of sources. But what's important to know here is that the groundwater sources had a higher level of ultimate free chlorine residual delivered to the final consumer. And this is somewhat expected because surface water is typically more likely to be contaminated either with bacteria or organic contaminants that would use up that chlorine and prohibit the ultimate residual being delivered from being adequate. So I want to talk also about the communities themselves. So as I mentioned, there's 300 communities in this data set, and we're wondering how chlorination processes change through time across these communities. So imagine you go into a community and you take 10 samples over the course of the year, and all 10 of those samples have chlorine above that 0.2 milligrams per liter standard that I mentioned. If that's the case, that's 100% of samples being chlorinated, and they fall into this blue category of 100% chlorination. So this figure shows the year on the y-axis. On the x-axis is the proportion of communities within each of those categories. So you can see immediately that in 2013, we had the lowest proportion of communities delivering that 100% level of chlorinated water. Whereas by 2021, over 60% of communities had 100% of samples with adequate chlorine. And you can see as this blue box is increasing, this orange box, the 50 to 75% seems to be decreasing pretty steadily. And so that's likely the group that we're converting from, an occasional chlorination to consistent chlorination. So there's a couple of probable reasons for this shift through time. The first is that circuit rider program I mentioned before. Again, the circuit rider program is the technicians who visit on a monthly basis and perform monitoring, but they also perform training and capacity building within the community to ensure that chlorination is happening. So when they're coming up to chlorination samples that are low in chlorine, they can administer training and actually handle those different problems and train the community how to better chlorinate in the future. So since that began in 2013, you can see that the technicians have improved their capacity in actually handling those lapses and improving the chlorination of water being delivered. So when I say lapses in chlorine, what kind of problems are leading to these lapses in chlorine? So again, this is another time series data set of the types of failures or types of lapses in chlorination, beginning in 2015 when they first started recording these problems. So the warm colors here, I'll walk you through the year 2015. The warm colors here show technical failures. And so the orange bar is failures related to the chlorinator itself, whether it's dosing incorrectly or perhaps not operating correctly. The red bar, thank you. The red bar shows no water present, which means there was no chlorine sample able to be taken because water was not flowing through the system. Now the cooler colors here, the blue, show problems related to the community water board. So lapses due to human choices. And so the lightest blue color here shows no chlorine purchase. That is, the community water board failed to purchase chlorine in that time period. The second darkest bar here shows a habitual problem, meaning that every time technicians visit, this community is consistently forgetting to put chlorine in the chlorinator, or they're choosing not to do so. And finally, this darkest bar is the occasional problem related to the community water board, meaning that technicians regularly visit this community and see that they are chlorinating, but perhaps they just occasionally forget to replace chlorine. So there's two major trends here that I want to highlight. The first is the chlorinator related failures, which have diminished really significantly since 2015 to so far in 2021, no failures attributed to chlorinators themselves. And then second, I want to highlight again this occasional problem with community water boards, which is steadily either increasing or becoming a pretty consistent portion of the failures represented in each year. And so that would suggest this is really a good target for circuit riders to approach to continue to improve drinking water. So I want to leave you with a couple of important key takeaways. As I mentioned before, 67% of these point of use chlorine samples across these communities are meeting the WHO drinking water standards, but also falling below that taste aversion threshold. But what's perhaps more important is that the proportion of communities routinely chlorinating is increasing. And I think that can be attributed not to the chlorinator alone, but also to the EOS circuit rider program. And this circuit rider program has additional opportunities for continuing to improve water safety amongst these communities, particularly by focusing on these occasionally forgetful community water boards. They can even further improve water safety. So a couple of future research and future interventions that EOS has been considering deploying, one of which is optimizing circuit rider visits so that their highest performing communities, those 100% bars, are visited less frequently so that circuit riders can focus their time and energy on communities that are more often forgetting to chlorinate. And the second would be aiding these circuit riders in their jobs by having water quality sensors installed within these systems that could determine whether or not a community is adequately chlorinating more rapidly than having a circuit rider visit monthly. And that idea is known as like a smart chlorinator, which has this improved monitoring capacity so that we could send technicians more like an ambulance rather than on a circuit basis to any community that needs assistance. So I want to really quickly acknowledge the EOS International staff and my advisor, Dr. Craig Just, and I'll take any questions at this time.
Thank you so much for that. That was a great presentation. You already have 2 questions in the chat, and once again, everyone feel free to add questions to the chat. If we don't get to them, our speakers will be able to get to them after the session. So the first question is from Joanne Barlow. Why do you think the percent of communities with less than 25% has not really changed over 8 years in any systematic area? And then it's a multi-part question, so let's start with that first part.
Okay, yeah, I can start with that. Thank you for your question. So I think part of the reason that could be is that those are communities that are perhaps adverse to chlorination, whether that be because of the taste or because of an inability for the community to be paying for those chlorine tablets. So my inference would be that those are a pretty consistent set of communities that are opting out of chlorination as opposed to forgetting to do so.
Great. So then the next part of her question is the number of failures related to no water present is increasing. Does that mean that they are becoming more water stressed over time?
Yes, that's a really good point, and I didn't have a good chance to highlight it. That would be, yes, our inference on that as well is that this is probably somewhat climate reported, and this is reflective as well of things that are being reported by individual community members and community water boards to EOS as a whole, is that they're increasingly finding it difficult to have water flowing through their system consistently. So yes, I would attribute that at least somewhat to climate.
Thank you for that. Yeah, it's a tough development. So Joanne has another question, so if you want to answer that in the chat afterwards,
Sure.
But we'll jump to Aaron Bivens asks, are members of the Community Water Board compensated for their services? Is it viewed as volunteer or professional?
Yeah, so that's a great question.
Yeah.
So the majority of the water board is not compensated and is voluntary, but usually there is one individual who is in charge actually of replacing the chlorine tablets, and they are also in charge of collecting any kind of water fees that the community may require for both the water provision itself as well as the chlorine tablets. And so that community member is usually compensated from that same set of money that's collected, be it fines, or not fines, but fees. So yes, it is voluntary except for that individual. And it's rotational. So it's only a year or 2 that you're in this position, and then someone else can be elected to that position.
Great response. So then we have time for one more question, and Lee asks, any chance culturally appropriate SMS reminders may help water boards?
Oh yeah, that's a great question as well. And that actually kind of speaks a little bit to that smart chlorinator model that I mentioned before. Yes, so currently EOS is delivering text messages reminders to community water boards to replace their chlorine. That's something that they've started scaling up, particularly due to COVID in times that they couldn't visit communities in the past 2 years. But it's also something that we would hope to integrate with that kind of smart monitoring system where sensor data could actually trigger an automatic message to be sent to a community member in charge of replacing that chlorine. So they could be reminded that that needs to be performed or is currently not being performed correctly, for example.
Well, thank you, Sally. That's all the time we have. I got to agree with Patrick Thompson, who in the chat says, thanks for a great presentation. That was fantastic. And you have 2 or 3 more outstanding questions left in the chat if you want to answer those afterwards. But that is all the time we have with Megan. And so if you want to stop sharing your screen, and we will transition over to David Meyer with the University of Toronto. So David, yep, see that you're sharing screen. If you're ready to go, you have 10 minutes.
Great, thank you. My name is David Meyer, and on behalf of my co-authors, I'm pleased to present to you Sensing Inconsistently Used Water Treatment Devices in South Africa. I'll tell you about our sensor, the Smart Spout, and how it works, why consistent use is so important, how surveys often overestimate it, how a good water treatment device at a household level needs to account for inconsistent users, and about sensor-enabled opportunities to change household behavior. This project started with my co-author Natasha Wright and myself when we took Susan Murcott's class on WASH at MIT. She found out she had 2 mechanical engineers in her class and asked us, can you make a sensor to objectively measure household water treatment and safe storage devices and when they're used? We thought it'd be a few weekends worth of work, and 10 years later, I'm here to present you what we've done. We looked at treatment devices, and most of them have a spigot, and that's where we put our sensor. We replaced the standard thin plastic handle on a standard spigot with a thicker plastic handle to embed our electronics. The key piece of circuitry is the accelerometer, not measuring acceleration in a car, but measuring acceleration of gravity. So it knows the angle of the handle and can tell when the handle's tipped up or tipped down. When the device is used and then turned on and then turned back off, the device wakes up and logs what day is it, what time is it, and how long was the device left open. You collect the data by putting your smartphone on the Smart Spout, and the data is communicated using a protocol called near-field communication, which is a lot like an RFID tag that you might use to get into the subway. Because our electronics are hidden in the handle and they just use an accelerometer, we're able to have a cost of approximately $20 per sensor, which is often on par with a household water treatment device itself, which we hope will unlock new opportunities for sensors at scale. So when the sensor was working, we partnered with co-authors Courtney Hill, Kelly McCain, and Elizabeth Rogowski-McQuaid at the University of Virginia. They were halfway through a large randomized control trial in the Limpopo region of South Africa. The trial worked with 404 households and 4 arms. There was a control group, a safe storage only group, a safe storage with a silver releasing tablet, and a safe storage device with a ceramic filter in it. And the trial was tracking 2 key outcomes: child stunting measured 2 different ways, and diarrheal prevalence in children in that household. And sadly, the trial found no association between either stunting or diarrheal prevalence and household water treatment and safe storage devices. This was disappointing, but not unlike other large results we've seen as a WASH community. And I think a lot of us have been left wondering, what does this mean and what should we do? In this case, we have really interesting data on how often the devices were used, and that's what I'm going to tell you about today. We put Smart Spouts on each one of the 3 arms and got data from 241 households, which was 86% of the households, over 9 weeks. We had a software memory hiccup in this version of the program that meant we only got 9 weeks of data, but it's still 2,000 sensor weeks of data. And I'll tell you about part of those results today. So rather than telling you about every household and every time they use their water filter, which was over 60,000 times, I threshold the data for this presentation. And so I simply tell you, house 1, day 1, did they use it or did they not use it? And I apply a simple threshold of the household's total use needed to be at least 5 seconds. If you opened your spout for at least 5 seconds at different points during the day total, you counted as using your filter, and that corresponds to approximately 300 milliliters of water. So the results were pretty good. Most households use their device most days. The median household used their device on 82% of days, and the mean household on 74% of days. So why didn't we see benefits? Because health benefits from water treatment are non-linear. Linear is that orange line, that yellow line, and that's not the case. Some simulation studies of what health benefits should we expect from water treatment suggest highly non-linear results, and that maybe you even need more than 95% adherence before you can even get a majority of the health benefits from your water treatment technology. So if you take away one thing from this presentation, do not use an average when you aggregate your adherence data, because that implicitly treats the benefits of adherence as linear. There's no perfect answer for what you do instead. What we did was we used a term called consistent use, which we defined as having used the device 7 days in a row. And if households wake up every morning and flip a biased coin to decide, am I going to adhere today? This consistent use definition is equivalent to their single day use probability to the power of 7, which allows us to compare it to this modeling work done by Brown and Klassen. And we're certainly a lot closer to their model than the linear assumption. And so we use this consistent definition, 7-day use streak, to ask again, what did the household distribution of use look like in our study? And we find quite a different story in blue. Most households did not consistently use their device. The median household had consistent use threshold achieved on only 31% of days, and the average household only on 39% of days. And this lack of consistent use can help explain why we didn't see the health benefits we were hoping to see in this trial. So this nonlinear use might seem discouraging, but nonlinear systems can have benefits. And here's why I think this is exciting, is that if we focus our behavior change efforts on that steep side of this curve, they can have huge health benefits. So if you have your behavior change agents of your project, instead of focusing on every household evenly, if they focus on high but imperfectly adhering households, their efforts can result in huge health benefits for those households because they're pushing them up that steep part of the health benefits nonlinear curve. So I think more projects should pay attention to which households they're targeting and focus on those high adherers. But if you believe me, how do you find those households? You could take a survey and ask households, did you use your intervention yesterday? In this randomized control trial, when we did that, 98% of households said they used the intervention yesterday, which overestimated our single-use prevalence by 24 percentage points. When we asked in a given week, how many days a week do you use the device? 92% of households said 7 out of 7 days, which overestimated consistent use by 53 percentage points. So if you do want to find these high but imperfect adherers, you need accurate longitudinal data, and sensors rather than surveys are an effective way of gathering that data. Sensors can also help explain unusual events in a controlled trial. So in one of our arms, we had a tablet that was releasing ionic silver into the water, and we found several houses had silver concentrations above the WHO guidelines. The sensor measured usage of those households helps suggest a reason why that would have occurred. Households with low adherence often were the households with high silver levels. And we can develop a probabilistic model for this. If these households again wake up and flip their biased coin to decide, am I going to use all my water today or leave it sitting stagnant in the bucket? We can predict the stagnation time in days as a function of that use probability. And that gives us a stagnation time mean, but it also lets us derive a 5th and 95th percentile confidence interval for our stagnation times. This isn't just about silver. This has contact time implications for chlorine, iodine, bromine, even sodas. If you're building contact time-based devices, you need to account for inconsistent users.
2 minutes.
When we did that for our silver data, our 95% confidence interval explained 95% of our silver measurements. And in fact, when we looked at the data this way, it made sense that we had silver exceedances. About a third of the households were using their device less than 65% of days. And if you're not using it 65% of days, there's more than a 5% chance you exceed the WHO threshold because of water sitting stagnant. But beyond just looking backwards, sensors can help change behavior. We're looking for new partners and new funding to help us explore this. Beyond just paying for behavior, we want to do schemes like use or lose, where households get a fancy new filter, but it's given away to a different household if they're not using it. Where households see their neighbor's data compared to their own data, or where behavior change agents get data on when a household is using or not using their device so they can follow up with targeted behavior change questions like, why aren't you using your device on Friday mornings? So I've flown through a lot of ideas about consistent use and why it matters in monitoring, evaluating, and designing household water treatment devices. I think the smart spouts and sensors in general are a great option for measuring consistent use. I advocated that you should focus on high but imperfectly adhering households, that if you want to find them, surveys are not the way to do it, and that if you're designing water treatment devices, they need to incorporate the uncertainty associated with users, and would love you to partner with us as we figure out how to use sensors to change behavior. This work was not possible without lots of funders and lots of help, and I would love to take your questions. Thank you. I got told to fill time until I see questions in the chat, so I'll just tell you briefly, my research group is coming out with a diarrhea sensor that's based in latrines, and I'm at the Center for Global Engineering at the University of Toronto, which is hiring for a new engineering faculty member. So if you're on the job market, apply.
This is a fantastic presentation. Thank you for that. As a mechanical engineer in Wash myself, this is very entertaining. This is stuff that gets me excited. So one question that I have for you while questions come in, and feel free to throw questions in the chat from all of our attendees. So you're talking about behavior change. How do you think that knowing that you're being fact-checked potentially might change behavior for survey responses?
Sure, we didn't have a blinded arm, so households knew they were being observed. Some of the studies that have used deception suggest there is reactivity that lasts on like the order of many weeks, and so potentially even including the whole observation window. So our results may be an overestimate. If reactivity is really that strong, we should just lie to people and tell them they're being watched all the time by sensors that don't exist, because that's way cheaper than a sensor that does exist. Maybe I shouldn't say should. Yeah, I think in the data, we didn't see evidence of short-term reactivity. So you were equally likely to have used your device the week before or the week after someone showed up to collect the data. Was one of the places we looked for reactivity and weren't able to find any.
Thank you for that. And then, as you may see, Claire had asked, do you think that the use it or lose it mentality could create some hostility between the community?
Yeah, so incentive designs are always tricky, right? If you make the incentives too strong, people will adhere just for the incentive, or people will fake the data. And if you don't make them strong enough, nothing changes. Potentially create some hostility. Yes. Ultimately, kind of there has to be some pain or some incentive if it's going to motivate people. But yeah, those would be good things to keep be mindful of going forward.
Definitely. And yeah, if you want, I can read them off, or if you want to.
I got them.
Okay,
so
as long as you read them out loud, that's great by me.
Great. So Joanne asks, do you have any idea of how long sensors last before breaking or needing maintenance? Well, in this case, 9 weeks, which was far shorter than we wanted. The next version, I mean, it was like one line in the software code that needed to get uncommented. They were designed for a year of use. They log something like 5,400 uses, but it depends a little bit on how many of those uses happen because someone's carrying a bucket of water on their head and is shaking the sensor. Rather than opening and closing the sensor, which is one of the disadvantages of using an accelerometer. Aaron asks, lots of ideas, fair critique. How reliable is spigot use as a surrogate for, quote, treatment? Any chance someone could dump untreated water into their storage container? Yes, that's definitely possible. I didn't go into the results that are group-based. The ES&T paper that's linked to in the slide deck does, and we found evidence that suggests that people preferred the devices that were more like just a safe storage container. Perhaps because they were just dumping raw untreated water into them and not waiting for the mandatory contact times. I don't have data on why that was the case, but there was a strong preference for both safe storage and tablet-based devices in the adherence data. Lee Voth Gedert asks, are there market-oriented applications for the sensor? Wholesale price is then 40, now 20. Could this deter direct sales, or do you feel like it's primarily oriented for government applications? So as we think forward towards a future where sensors become cheaper and cheaper, like I would love a sensor in every device, right? Your Brita filter in your fridge has a mechanical counter that tells you when it's time to change the filter. So in the world around us, there are already sensors that tell us when it's time to change or do things differently with our water devices. And I think the heuristic of on the same order of magnitude as the device itself is kind of the flag for the tipping point when sensors could become part of every device rather than just used in research or government programs.
Real quick, you have about 30 seconds for this last one.
Great. So Neil Van Dyne asks, does the sensor data have a timestamp? Yes, it has both a date and a time. The technical answer is there's some uncertainty on that timestamp because of how we have to compress our data to get it to fit on the near field communication chip, but in broad sense, yes, it does. Great. Well, thank you all for your attention.
Yeah, thank you so much, David. That was a fantastic presentation and great answers and response. You can stop sharing now. And so that is it from our presenters. Once again, I would recommend that if you have additional questions,